Okay, this week I thought we'd go to the back of the head. So we're looking at the bones of the skull, and we're going to look at the occipital bone, the bone of the occiput. The main reason we're going to do this is because we're going to relate the anatomy that we find to fracture of the base of the skull. Alright, so we'll look at the bone, the bones around it, the sutures, the foramina, the lumpy bumpy bits, because there's some good features, and things like that. We'll work our way around just that one bone, and then at the end we'll see if you can relate what a fractured base of skull might also damage. I've got to be careful where I sit because my tree's shedding berries, so there's soft berries and bird poo. Hopefully I can tie in a little bit of VR as well, a bit of virtual reality models, because I'm still at home, I still can't go into work, and I still haven't got a real human skull at home, funnily enough. But the occipital bone then is a single bone, so it's a bone of the cranium, a bone forming the cranial cavity in which the brain sits, and some of those bones are paired, but the occipital bone is a single midline bone at the back of the head and also the base of the skull, and that's an important idea. That's why we're really exploring it, because when we talk about the occipital bone, people say, oh yeah, it's there, but it's more than just there. So we've got two parietal bones that it meets, so we have the occipital bone meeting the left and right parietal bones, and then also laterally we have the two temporal bones, so it also meets the two temporal bones. And then the other bone that it meets is the sphenoid bone anteriorly. But to work out how that meets, we have to look quite carefully at the base of the skull or the internal parts of the skull. The sutures are fibrous joints that link the flat bones of the skull. So the occipital bone is largely a flat bone. The most important suture is the lambdoid suture. It's kind of making this upside down Y shape, or a V, whereas the lambdoid suture is making the V shape, and that's between the two parietal bones superiorly and the occipital bone. So that's the most important suture to be aware of, but there are others, and they're named quite sensibly when you know about the parts of the occipital bone. So okay, so the lambdoid suture is forming that upside down V. Now at the tip of that V you might be able to palpate a little depression. So if you go, there's a sticky outey bony bit which we'll come to in a minute, and then superiorly to that you might be able to palpate a little depression. That little depression then is lambda. That's the apex of that V in that suture there. So that's kind of a cool landmark. Now I say that the occipital bone is a flat bone, and that flat posterior part, I say flat, of course it's curving because it's making a curve, isn't it? Making the curve shape of the cranial cavity, but it's a flat bone, not like a long bone. So that flat part of the occipital bone is the squamous part, and that's a common term, isn't it? Because the temporal bone has also got squamous parts. So squame is a flat, a squamous cell is a flat cell. So the flat part of the occipital bone is the squamous part, and then the rest of the occipital bone, the bit inferiorly that extends all the way anteriorly to the sphenoid bone, the bit that's forming a large part of the base of the skull, that's the basilar part. So the base of the skull is largely formed by the basilar part of the occipital bone. And the big feature of that basilar part is foramen magnum, that big hole that the medulla oblongata passes through to the spinal cord, right? That hole is within the occipital bone. And then so you might hear the lateral parts, the bits of the occipital bone lateral to the foramen magnum get called the lateral parts. Now you know that, you can start working out the names of the sutures, the other sutures. Right, so if the lambdoid suture is the most important part, I said that we've got the temporal bone on either side. Now the temporal bone has also got a number of parts, and we've talked about this in the past, I think. So we've got the mastoid process here, which is this lump posterior to the ear, and you've got the petrous part, the rocky ridge, the rocky part of the temporal bone, which houses the bits of the inner ear, right? There's that lumpy rocky bit, and those two bits meet the occipital bone, giving you the occipitomastoid suture. But okay, so what's the name of the suture that links the sphenoid bone to the basilar part of the occipital bone? It's the spheno-basilar suture. And I mean, I say suture, it kind of becomes fused really, it kind of disappears whenever we look at skulls. But okay, so those are the connections between the occipital bone and the bones around it. Sphenoid, temporal, parietal, lambdoid suture, okay? Okay, the foramen. Right, so I said foramen magnum is the big landmark, the big hole, and that's within the occipital bone, the basilar part of the occipital bone. Now, the other foramen are actually gaps between the occipital bone and the other bones. For example, look at the jugular foramen. It's actually a gap between the basilar part of the occipital bone and the temporal bone. So the other foramen here are, well, a couple of them are gaps between bones. What's running through it? Well, the internal jugular vein starts here, so most of the blood from the cranial cavity drains through here. Ooh, that's important. And you've got cranial nerves 9, 10 and 11 dropping out through here as well, right? So the jugular foramen is not a hole within the occipital bone, it's a gap between the occipital bone and the temporal bone. And we see the same thing with foramen lacerum. Foramen lacerum is a little bit more anterior, and foramen lacerum again is a gap in the remains of the bony skull, in what we've got left after death. If we take everything else away, foramen lacerum is a gap between the sphenoid bone, the basilar part of the occipital bone, and the temporal bone. But the thing about foramen lacerum is that in life it's actually a joint between those bones. So it's filled with cartilage, it's a cartilaginous joint. There's not really anything going through there except maybe a few emissary veins. And foramen lacerum has the internal carotid artery sat superior to it. But it is a hole that you see in the bony skull, so we'll mention it. Also then, we'll talk about lumpy bumpy bits in a minute, but the occipital condyles are two lumps on the inferior part of the basilar part of the occipital bone, and those occipital condyles are going to articulate with the first vertebra, with the atlas, right? Yeah, that's how they anyway. And just superior to that, we see a couple of holes which are condylar canals, which are carrying veins back from the occipital region of the scalp back towards those other veins that are draining blood from this region. So they're not terribly important, but you've got the hypoglossal canals. The hypoglossal canals are holes, are canals rather than foramina, which are running anteriorly. And they're just superior to the occipital condyles. And of course the hypoglossal canals are carrying the hypoglossal nerves, cranial nerves 12, hypoglossal, they're going to go beneath the tongue, so they're running anteriorly. So the hypoglossal nerves are also running within, essentially, the basilar part of the occipital bone. So if you know about the condylar canals and you know about the hypoglossal canals, you don't tend to mix them up, you see, that's why it's worth mentioning. But the hypoglossal canals are the important ones. So foramen magnum, jugular foramen, foramen lacerum, hypoglossal canals, condylar canal. That's it. Those are the foramina. The last thing to consider are the lumpy bumpy bits. Now we've got two surfaces, so we've got to consider the internal surface and the external surface. Right, external is easiest. You can feel that lump on the back of your head. So we talked about the depression of lambda, and then there's a lump just inferior to that. So that lump is the external occipital protuberance. If there's an external occipital protuberance, there's likely to be an internal occipital protuberance. But that's the lump that you can feel there. And what you probably can't feel, well, running inferiorly from the external occipital protuberance in the midline is the external occipital crest, also known as the medial nuchal line. The nuchal ligament attaches here in this midline. You can feel this, right? So if you find the external occipital protuberance and you palpate that, and you move your fingers a little bit inferiorly in the midline, and then you nod your head anteriorly, you'll feel the nuchal ligament spring up. And the nuchal ligament then it's this. So the cervical spinal cord has this bend in it, right? And the nuchal ligament then runs. It kind of fills in the S of the bend there, and it's this long flat sheet of ligamentous connective tissue, which then other muscles and connective tissues and bits and bobs can attach to, because your head's very heavy, right? You've got to hold your head up. And that then attaches to the occipital bone in that medial nuchal line, or that external occipital crest. And then we have superior and inferior nuchal lines. The superior nuchal lines are quite easy to see on a skull. So again, you go back to the external occipital protuberance, and then running laterally outwards on either side are two ridges on the occipital bone. Now if you've got ridges on bones, that's where things attach to the bone, right? That's what the ridging is caused by, is that interface between the muscle, the tendon rather, or ligaments and what have you, attaching to the bony bit. Anyway, so the superior nuchal lines are at the same level as the external occipital protuberance, and I can palpate mine on either side. So we have the muscles of the neck inserting in there, and then about halfway down the medial nuchal line, halfway down that external occipital crest, there are inferior nuchal lines, which I might imagine I can palpate, but I'm probably not really. You can just about make them on a skull, make them out on a skull. So superior and inferior nuchal lines. And then the other obvious feature which we've mentioned, which you definitely can't palpate, are the occipital condyles, those big bony lumps underneath that articulate with the first vertebra, with the atlas. It just sat on a slug. The sun's coming up. Anyway, okay, so inside the occipital bone then, we're in the posterior cranial fossa, which is where we find the cerebellum. And then anterior to the cerebellum we find the pons and the medulla, and then superior to that we find the cerebral hemispheres, right? So, as you may have guessed, and certainly as I alluded to earlier, on the internal surface of the occipital bone we find an internal occipital protuberance, right? Now from the internal occipital protuberance we also see an internal occipital crest. And okay, so think about what structures have we got here next to the bone on the internal surfaces of the occipital bone that will attach to it. So that median internal occipital crest, median because it's in the midline, and the internal occipital protuberance, this is where the falx cerebelli is going to attach to the bone, right? These folds of dura mater support the soft parts of the brain. We have the tentorium cerebelli over the cerebellum, we have the falx between the left and right parts of the cerebellum, and it all supports and holds the soft tissues in place within the cranial cavity, right? So from the falx cerebelli superiorly we see the falx cerebri supporting the two cerebral hemispheres. Okay, so the internal median or median internal occipital crest is a site of attachment of the dura mater, that falx cerebelli. And then we also see kind of from that internal occipital protuberance running left and right, horizontally as it were, around the internal surface of the occipital bone, we see grooves for the transverse sinuses. So the transverse dural sinuses are collecting blood. Those are spaces within the dura mater which are going to eventually drain to that internal jugular vein. So we see those grooves there. So in fact we actually form a cross of ridges and grooves and bits and bobs around the internal occipital protuberance, and that cross gets called the cruciform eminence. The other internal bony feature that I think is really important to get to grips with is the clevus. So if you look at the internal surface of the basilar part of the occipital bone and you look at foramen magnum, the slope of bone that's running anteriorly from foramen magnum up to the sphenoid bone, that slope is the clevus. Clevus is the Latin word for slope, I think, isn't it? And, okay, the reason this is important is because up against the clevus is the pons and the medulla, and between the pons and the medulla and the clevus runs the basilar artery. That's why it's called basilar. Everything's just called basilar in this region because it's the base, right? So the basilar artery is running next to the clevus of the basilar part of the occipital bone, and that's an important idea. So that leads. Okay, so we've looked at the bone surrounding it, the sutures between those bones, the foramina, the lumpy bumpy bits. We've looked at the parts of the occipital bone. So now we can kind of take that information and use it when we're thinking about a base of the skull fracture. Now this isn't a comprehensive thing, this is just an anatomical exercise to get you to think about the anatomy and apply it to injuries in that region. Okay, so if somebody, basilar skull fractures, a fracture to the base of the skull is, they're kind of quite difficult to do because as we've been looking at the occipital bone, hopefully you've appreciated that much of it is quite thick, it's quite tough. So you need a significant blow to the base of the head, which I think as usual is most common in road traffic collisions, but can be caused by other things, to damage this bone. But you've also seen how this bone joins to surrounding bones and that there are foramina running through it carrying important things. So a fracture to this region, what could be damaged? Well, okay, so we were just talking about the basilar artery. So if the clevus is fractured, then the basilar artery is at risk. The basilar artery is supplying blood to the brain. So the basilar artery and the two internal carotid arteries are going to supply blood to the cerebral hemispheres. But more directly, they're supplying blood to the pons and the medulla as they run past it. And the pons and the medulla are vital for life. So the basilar artery is an important structure. If there's a fracture, because you've got other bones here as well, but a fracture in this region can cause bleeding, so then we might see blood collecting around the mastoid processes, and you might see blood tends to collect around the periorbitally, around the eyes, which get called panda eyes, because we see that the internal jugular vein is running through the jugular foramen. We have a number of dural venous sinuses collecting here, so a tear of dural spaces, a tear of dural venous spaces can give leaking of dural venous blood, which will then collect and pool in spaces. You might also then, because we've connected the occipital bone with the petrous bone of the temporal bone, we've connected this region to the ear. So of course the meninges inside the cranial cavity are also containing cerebrospinal fluid. They're holding the cerebrospinal fluid that the brain is floating in. So if those meningeal layers are damaged with a basilar skull fracture, then you might see leaking of the cerebrospinal fluid, so to the ear or from the nose, so a constant drip of clear fluid. If we're thinking about the jugular foramen, then we also need to worry about cranial nerves 9, 10 and 11 and where those go and what they do and if they've been damaged, and then also the hypoglossal nerve. And you can test these things really easily. The hypoglossal nerve is the nerve that innervates almost all of the muscles of the tongue. So if both hypoglossal nerves are functioning, you can stick out your tongue. If one of those hypoglossal nerves is compressed, damaged, severed, crushed, the tongue will deviate to the side of the weakness, things like that. So do you see how considering the anatomy of the occipital bone and then layering on top of that your knowledge of all of those other structures that are running adjacent to this bone, through this bone, you can work out what's going on in a basilar skull fracture, you can work out what's going on in your patient. And that's what studying anatomy is, it's building blocks. And it's slowly putting those building blocks together until you have a comprehensive knowledge of anatomy and you can work stuff out, you can work out what's going on. But that's why it's worth kind of studying these bones in isolation. When you look at the skull as a whole, you point at the things, it's kind of, yeah, I can do that and that. But if you consider the bone in isolation, and then you consider how it links to other bones and spaces, anyway, you get the idea. Right, enough prattling on. That'll do. See you guys next time.